morning, Barbara.
Yes, yes. Um, Good morning. My name, let me say, is also, besides Mignon Smith, is Nana Ajua Kodie Boma Nkosohima. And what we do with the Global Associates for Health Development Incorporated, we support a village in Ghana, Boma Village. And all that we do and all benefits go directly to Boma. And this morning, we're presenting our first webinar. It's actually our 10th symposium, and our first webinar on characteristics of aging. Let me introduce our presenters. First, we're going to have Dr. Reza Nagavi. He is a practitioner of wellness, and he will speak to biology and physiology of aging. Also, crucial factors of influence and comorbidities. Dr. Robert Reese, who is a dentist, will discuss dental perspectives. Barbara McFadden, she is a nurse and specialist in senior living, and she will speak to us on that topic. Also, we're having Melody Graham, who is a lawyer and a financial expert, and she will discuss the economical factors when one is aging and what they have to adjust to. So it's Reza Nagavi, are you there? I guess he's trying to get on. All right, let me speak to aging. What is aging? Actually, in the literature, it's compiled of phenomena consisting of physiological, psychological, and social adaptation to cultural environment. Someone once said that at every station, there are several stations in life, and it begins with, oh, there's Reza Nagavi.
Yes, good morning.
Good morning.
How are you doing today?
Fine, thank you. Let me say this very briefly. Stages of development, we have in the beginning, infancy, that's the first station, and dependent upon what we experience, physiologically, psychologically, socially, it will affect us at that station if we maladapt. The body constantly seeks for homeostasis or balance. So if anything disrupts the balance, the normal balance during the infancy stage, we might not progress normally to the next stage. All right, that's toddling. And then we go into puberty. Any disruption in the normal phenomena of environment, physiological, social, psychological, etc., disrupts our adaptation or our balance. And I think Dr. Nagavi will discuss that more fully, because if we have any imbalance at any stage of development, we might develop comorbidities or morbidities. Okay. So Dr. Nagavi will discuss the physiological and psychological, social development and biology.
Good morning, everyone. My name is Zoe Nagavi. I am honored here to be able to share a few words with you as far as the aging process is concerned. Aging is a process that starts from the moment of inception and carries through all the way to the moment of termination, or the time that we no longer are the custodians of this physical being. The aging process at the conception goes through a slew of genetic processes, replication, duplications, and expansion. And our bodies become, through stem cells, our bodies become a factory that will be able to produce tissue, cells, so on and so forth. We, at the time of birth, are, and as far as the genetics are concerned, are using telomeres that have a certain amount of length, that every time we duplicate and replicate a cell, the size of these telomeres will start to become smaller and smaller, to the point that these telomeres are no longer functional, and that causes the apoptosis, or the death of a tissue. We have some 13 trillions, I don't know exactly how they estimated that, but cells within our bodies, whether these are cells of your skin, your musculoskeletal, your cardiovascular, your neuromuscular, or your digestive, or your endocrine, or a slew of other pieces that together run our body as a perfect machine. At every stage of life, including the prenatal period, our body is receiving nutrition and is receiving signals that will be able to help our bodies form the best factory, the best machine they can form without fault. These signals will continue to be there and affect our lives, even to the moment of death, how we get sick, how we respond to illnesses, and so on and so forth. If we are given the proper oxygenation during our embryonic period, we're given the proper nutrition, proper vitamin, proper ambient, temperatures, stressors, and other things, then it will grow to become a much better product once the baby is delivered and the machine goes to functioning, fully functioning. If we are given stressors and we are given lack of oxygenation by smoking, or cultural issues as hard labor and working and not resting, and malnutrition because of not eating properly, or enough calories or enough vitamins, if we are drug users and we subject this embryo and this fetus to factors that are not necessarily to the best of its interest, then during the birth, during the childhood, adolescent, aging process, all the way to become elderly, we will be paying for this error or mistakes or lack of proper addressment of the needs of this machine. Our bodies are, we're basically a bunch of cells connected together to give this physical appearance a structure. And the structure could be from your skin and nail, and going a little deeper to your muscles, and a little bit deeper to what supplies the muscles, to the fascia, to the bones, and to the joints. And then if you look at the organ systems, whether you're dealing with cardiovascular organ system, or you're looking for at gastrointestinal organ system, or digestive organ system, urological organ systems, neurological organ systems, kidney functions, liver functions, and so on and so forth. Every one of these, to a normal aging process or to a normal development, will have an ultimate and optimal amount of production and structure and how this structure is subjected to environmental or a normal aging process will take us to further down the road as to what we get back in when we are older. Our the elasticity of our tissues are optimal when we are younger, when we are in adolescent or young adulthood, and this elasticity of this tissue will start to decline. We will lose elasticity, we will lose flexibility, we will lose healing process, we will lose blood flow, we will lose pigments, and we will lose thickness. And this is just the process of looking at, the surface of our body. Our muscles are, as a child, are growing, and when we become adolescent to adults, we are working out, we are exercising, we are building, we are hopefully not abusing the joints, and they become stronger and stronger and stronger. But as we start to age, this process becomes somewhat reversed. We start to lose muscle tone, we start to lose muscle weight, we start to lose muscle strength, and we start to lose the flexibility, the stretchability, and recovery of minor injuries and things like that. As far as our skeletal muscles are concerned, the skeletal muscles are growing, hydrating, regenerating, and as the aging process goes along, due to lack of nutrition and other factors, that also starts to fail. We start to become less compliant, we start to become stooped, we start to become osteopenic, we start to become arthritic joints, we start to have pain in our tissues and in our ligaments, and so on and so forth. As far as our, let's say, cardiovascular is concerned, the cardiovascularly, we are developed like a machine. We will deliver the oxygenated blood, we will deliver the nutrition and everything the body needs through these very elastic, soft, pliable, compliable, and quick to respond to the need of vasoconstriction, vasodilatation, and responses to the need of increased requirement of cardiovascular. Whether the requirement is the muscle of the heart requiring oxygen and nutrients, or is the tissues of your muscles that you are trying to contract and expand, and how fast it goes there, how fast it gets consumed, and how fast it returns to you. It all depends on what you put into this engine again, nutritionally and functionally. As we get older, again, we lose elasticity of these arteries and veins, and we are no longer delivering as fast and bringing back as fast. We're no longer compliant to the point that we are able to respond to a very high demand for pressure and calm down very quickly. Our compliance goes down. Blood pressure and the blood vessels start to build up plaque. The plaque may not be completely obstructive, but again, it hardens the arteries and it hardens the circulation system and decreases the compliance of the body at time of a need. Heart attacks, strokes, claudication of extremities, and so on and so forth are just more terminal ends of the same process. As far as our digestive system is concerned, we are designed to absorb nutrients, we're designed to digest nutrients, we're designed to chew nutrients, to break them down, fill them up with enzymes, digest them, bring them to the gastrointestinal tract, absorb the things that it needs to absorb, and get rid of the poisons, put back the good stuff, extract the extra water, extract the poison, the uric acid, and so on and so forth. So through the digestive system, our bodies are supposed to grab as much of the nutrition as we can from the environment, from the food, from the good quality of food that we are supposed to be eating in order for us to function well. Well, as we go through our aging process, that process slows down as well. the nutritional absorption goes down, the digestion and the regularity goes down. We develop allergies, or we develop responses to our environmental stimuli, and we end up with constipation. A lot of people have problem with constipation. We end up with indigestion. We end up with a slew of problems that could be circulatory, it could be enzymatic, it could be fluid, it could be a whole slew of mechanics that are involved that would sort of take us from this point of everything is fine, we're functioning normally, we're absorbing everything normally, to the point of nothing is working, and you need to be able to give pre-digested or pre-processed food in order to be able to ingest it. Our good doctor, Robert Rees, is going to tell us about all of that. But at the end of the day, from that process to the end process, that system of digestion starts to fail. If we're talking about our neuromuscular or neurocognitive or neurological, again, nerve cells from the tip of your finger to your brain, to biggest nerve cell bundle. We are processing at a certain speed. We are processing at a certain synaptic responses, jumping from one to one like a very healthy, happy child, jumping from one synapse to the other, versus as we get older, these processes get slower and slower. If we don't get enough oxygen, we don't have enough blood flow, we don't have enough nutrients, we don't have enough vitamins, we don't have enough of this or enough of that, or if we are genetically predestined to not have so much of it, or in abundance of it, or when we were in the womb, we got subjected to some toxins and whatever the case may be, we're no longer transmitting. Whether it comes down to neuromuscular disorders, or it becomes neuromuscular disorders, or it becomes a process of neuropathy, becomes a process of, I'm sorry, I got something came up on my screen, a process of neuropathy, process of neuromuscular pain, decreased sensation, decreased agility, and so on and so forth, all the way up to, we are becoming forgetful, we are becoming absent-minded, we are forgetting to do this or that, we are having some short-term memory loss, or we are having some structural changes to the neurons and the synapses in our brains, causing tangles and neuromuscular, neurofibrillar entanglement, or neuro bundles that are no longer traveling and carrying your good, fast information down the road. So that leads to dementia, Alzheimer's, a variety of diseases that could be genetically neuromuscular diseases, and other things that could be genetically affecting us or environmentally affecting us. A lot of the problems that we're also seeing, it could be environmental that affects our neuromuscular. The same way environment affects everything. It's just like an ongoing factory. When we come across any toxins, whether they're sprays or whether they're this or they're inhalants or ingestions, or there's something bad in our food, or we're supposed to be taking antibiotic and we're taking carcinogenic supplements that are supposed to be, taken out of the food, but they're put in the food, that will affect our neuromuscular. As far as our endocrine system is concerned, we have certain centers and factors within our body that order certain hormones, our pituitary glands, our thyroid gland, our pancreas, our adrenal glands, our thymus, and so on and so forth, that are also supposed to function optimally, but at a certain point, we start to drop. I'm sorry, I didn't realize I was out. We start to drop in the functioning of the systems. So generally, a lot of the body's physiological control is initiated through growth hormone. It's initiated through our testosterone, our estrogen, our progesterone, and it's initiated through uh, whether or not these hormones are functioning properly from birth to death, or these hormones are being subjected to antibodies that could affect the thyroid gland that affects everything in the body, from your memory to your movement to your neuromuscular to everything that you can think about has something to do with your thyroid gland, has something to do with your estrogen and testosterone, has something to do with your growth hormone. So whether or not it is a normal aging process and everything starts to drop off sometimes in the 30s, 40s, 50s, 60s, 70s, 80s, and our body sort of goes through a physiological menopause, whether we are men or women, we go through a menopause process. And the menopause process is just our body is no longer producing the hormones that it once did. When you say to a male patient, you're going through sort of a menopause, they're like, what are you talking about? How could I be going through a menopause? I don't have this, I don't have that. But at the end of the day, that menopausal process is what part of the aging process will bring into play as well. Um, the hormones of fight, flight, sugar regulation, blood pressure, salt regulations, everything that you can possibly think of are responses to other stimuli from the pituitary or the brain area to the organ or to the gland that is supposed to produce a response. So those responses are normal responses. You hear something and you're like, I need a little bit more blood pressure or heart rate, or I hear something and by the time it sends a signal and I respond, maybe a much more flattened response than I would normally be able to give. Whether my adrenal glands, my salt, sweet, and sex areas that regulate whether it's your cortisol and it's your aldosterone and your sexual hormones and whatever, whether they work, whether they don't work, that will definitely affect the aging process. So we also, as we get older, as our body's good generation and regeneration starts to fail, and we start to become slower, whether it's slower in muscle movement, slower in mental responses, slower in GI symptoms, slower in our body's temperature regulation, slower to, being subjected that as a kid, you can get hot and cold, no problem. As an adult, you can get hot, but not be able to cool down, get cold, not to be able to heat up, and so on and so forth. Other organs in our bodies are also going through the same process. So you put in a request for to clean your blood through your kidneys, to filter through your kidneys, through your liver. The speed and the amount of blood flow that comes into the organ, the nephrons that are in the organ functioning, and the filtration system and the exchange of ions and good stuff and bad stuff to be separated, and to the excretion of what needs to be excreted. It's all, maximal and functional at birth, optimized at adolescent or young adulthood, start to maximize in our 20s and 30s, like everything else is maximizing, and it starts to decline thereafter. And through the aging process, just this filtration of our blood starts to change. The blood pressure affects the nephrons. The blood pressure affects the filtration system. The filtration system and the blood pressure affect the function of the membrane. The membrane that was doing so well is now filtering less and less and less of the toxins and more of the um, good stuff getting out of the system, causing damage to the tissue, whether it's caused from a blood pressure issue or it is caused from some sort of abnormality or a tumor in your somewhere in your body that says, give me more pressure, and that causing more damage and causing a perpetual declination of function. So kidney function starts to become very maximal and starts to decline as well. That's another problem that we go through kidney function or we go through the aging process. Whether that genitourinary system that also helps us get up at night to pee or don't get up at night to pee, or our prostate that gets older and gets thicker and gets bigger and gets more dysfunctional, causing us symptoms of urinary problems, whether it causes our symptoms of obstruction or incontinence, male or female, it doesn't matter. We can have different reasons. Drop bladdering is very common in the female population, and that could cause obstruction the same way as a enlarged prostate could cause a problem with obstruction. So normal functioning, being able to have control of your urine, bowel, normally, easily, and as you get older, losing control of this bowel function and urine function and getting rid of the toxins and so on and so forth. Liver, it's a factory. It's basically receiving tons of toxins, is putting in tons of hormones, making tons of cycles turn to regenerate this body. Environmental factors, alcohol, toxins, genetics, a gallstone, anything could affect this perfectly functioning liver that was delivered from the factory and it was been functioning properly, all of a sudden could go into a shock. And the function of the liver and the function of the chemistry and the digestive enzymes and ingesting enzymes and storage of fat and storage of sugar and everything else that it's supposed to do, it starts to decline. We develop liver failure. We develop high liver function tests, LFT numbers that we can sort of look at it. We look at it and it says, oh, we have fatty liver, we have a little too much storage, or we have a scar tissue, or we have vascular malformation in our liver, or we have little cyst in the liver, or we have little tumor in the liver, or. That could be, one of the things that also affects our overall function of our body. There are obviously many other factors in the aging process that come to play. Whether these factors are gender, whether men are worse off than women in aging process, or whether women have more longevity than men, that's one thing. Socioeconomic is definitely right up there with everything else because we seem to have, or we have a better grasp of our lives if we are more socioeconomically independent and better off. We have more time to pay attention to what we eat, more time to pay attention to what we smell, what we hear, the noise, where we live, where we go to school, and so on and so forth. So that socioeconomical link seems to be a pretty strong across the ages, across the entire world. People who are socioeconomically better off or more stable or comfortable are always doing better through the aging process, whether it has to do with nutrition or education or understanding of what life is, what stresses are, and putting them in the right boxes, in the right categories, and being able to deal with them. So that's always a very important factor, and it's been proven over and over and over that um, throughout the process of um, life, socioeconomic plays a huge, huge, huge um, uh, part of the aging process. Education, education is also very much linked into longevity, a healthier body, carrying this factory, this machine, this skin that we are living within to a better ending, to a better lifestyle, to a more comfortable, to a um, more fairer for this machine that all we do is give it food and water and it is functioning, it is working, it is producing whatever it's producing, but it's functioning. So um, education definitely plays a great role in the process of aging. Um, being married, having a companion um, is a affecting a factor in the process of aging, and the way it's being effective in the process of aging is through stress, through mutual understanding, through being able to share. We are basically a you know not designed to live alone. We're designed to have companionship. So our companionship, whether our companionship starts from being a child who was nurtured versus a child who was mentally or physically abused. We grew up and we grew up to learn and trust other people, or we grew up to be isolated and alone because of what we went through as an infant or a child or a young adult. And then having a family, a wife, a partner, someone to share with the stresses of life, to reduce the stressors, have a better understanding, and then being able to enjoy things, being able to enjoy better quality of mental, psychological, social, economical stages rather than being alone, becoming quote unquote a hermit, doing nothing, going nowhere. I don't do this, I don't do that, I don't want this, I don't want that, I don't eat this, I don't eat that. Or, honey, you have to eat this, you have to eat that. So that companionship, I guess, is part of that. Why people who are married and have within a family structure live a better, longer aging process than those of us who are alone, and so on and so forth. The other thing that we can look at through the aging process is we can look at how family structure, this is a reinforcement of what I just said, how our perception of family structure, what is the responsibility of a father or mother to a child, what is the intake of this child's understanding of having parents, having the pleasure of having their parents with them when they get older, and nurturing them the same way as they were nurtured, nurturing their parents when they're older, definitely leads to a longer, happier, healthier aging process. So that cultural divide seems to be intertwined in many directions, but definitely love and nurturing from the childhood to the death, and how you take care of your elders will have an effect on the elder population as well as your own population. Your parents live longer, they're happier, you're providing, whether it's providing financial or social or economic support and dealing with their doctor or whatever, or totally abandoning them, putting them, when it's impossible to deal with for yourself, putting them in a care facility and them being more alone, and then the quality of that care facility, whether they give them what they want, whether they give them that socialization or so on. A great deal of cognitive um, retention is tied into our perception of our neededness, whether we are needed and we have a function, ends up to be the cause lead better longevity and longer life and so on and so forth. And that's one of the reasons I think when men retire to nothing, within 5 years is our timeline, it's the most dangerous time because we lose that sense of usefulness. We lose that sense of need, that we are needed here, we have a function, we get up in the morning, get dressed, go to work, do this, teach, come back home, get money to do this, and keep going. So a lot of the times, not the sense of not being needed adds to the mortality and the morbidity of the aging process. So again, we are designed to be in groups, we're not designed to be loners, and so on and so forth. I've said a lot based upon what's going on in general, but what can we do to change this trajectory of, especially in today's world with diseases like COVID, that have been around for thousands of years, different versions of them at different times. How do we change all of this? Well, as custodians of this skin and this body, I think avoiding certain behaviors is the best. Not smoking, drinking maybe 1 or 2 drinks as few days of the week as possible, alcoholic drinks. Being active, physically active, have a routine. I get up, I go to the gym, I work out 3 days a week, I come home, I rest, getting proper amount of sleep. Sleep, is the most important part of your recovery, and allowing all your systems to sort of decompensate and compensate and regulate your blood pressure, regulate your circadian rhythms, and regulate your insulin secretion of growth hormones, and forming permanent memories from short-term memories, and so on and so forth. Very, very important. We tend to sleep less and less and less and less. We tend to be more and more and more and more tired. We are, we have to pick a balance between life and work. And unfortunately, in America, we don't have a balance between life and work. We work to live, to work to live, to work to live, to work to live. So we're constantly having to worry about work in order to just have a presence, in order to just be able to produce money, security, and so on and so forth. Whereas in many other cultures, whether it's an Italian culture, is Japanese culture, is South American culture, or Asian culture, or European, work is given a lot more importance in its place compared to life. In America, we're the hardest, longest working people around. And it may just be the way we are into a material things that we constantly need to buy, to do this, to buy, to do that. And they're constantly pressuring us that the engine must run, so we must continue to produce in order to function. So resting and having a balance between life and having a balance between work and having a balance between family, between exercise, food, choosing the right food quality of what we ingest in our bodies is extremely important, because that's where the toxins are coming in. That's where the poisons are coming in. That's how your body is going to start attacking your body. And that's how you're going to age systematically in different rates. Your heart is aging this way, your kidneys are aging here, your endocrine your endocrine system, or even your digestive system, or your um, insulin levels. Or everybody is now in a play. Depending on what you give them, everybody is having different stressors to deal with different things. So eating more organic and eating more monosaturated, um, and eating more grains and vegetables and salads, drinking better, purer water, cleaner water, not bottled water, which causes a whole slew of other problems. So nutrition is important. Once we realize we're not absorbing the vitamins that we need by checking your vitamin levels, supplemental vitamins, vitamin D2, calcium, B complex. Many of us are having trouble absorbing nutrients. Many of us are having trouble absorbing B complexes and slew of other vitamins. So supplementing the vitamins will end up being able to take us into a better ending result, causing less morbidity, less mortality, and less illnesses to deal with. They have uh, sort of gathered us into several different categories of how our bodies are to function, um, as far as the aging is concerned. And one of these processes is more of a digestive metabolic effects of aging, or metabolic aging, which is, will my body be a pre-diabetic? Will my body act like a diabetic? Will I become a diabetic depending on my nutrition and everything else that I go through? So will that be what my challenges will be? That's one process. Immune is another process of aging. So the immune aging is whether it's genetically predisposed or designed, that it runs in the family sometimes or doesn't, whether it's environmentally promoted because we ate certain toxins that our bodies have started to attack our bodies and cause connective tissue disorders and cause autoimmune disorders, whether we have been attacked by a virus to our thyroid gland and we develop a dysfunctional, hyperactive, hypoactive, dysfunctional thyroid function. It's all part of this immune complex. Will I suffer from severe arthritis when I get older? Have I been pumping 500 pounds of squats? Will my knees be paying for this when I'm older? Have I been cracking my fingers or not cracking them, which turns out to have no real effect? But how will my body's immunity respond to the environment? So that's it, autoimmune concept of that. I discussed already the liver and the kidney, or metabolism of being able to look at the factories, whether it's cardiovascular or otherwise. So metabolic, immunological, and centers of factories, whether it's your liver, your kidney, or your other things. Aging process in your eyes. We lose sensitivity to our retina, to the blood flow to the eye, the cataracts that come as the aging process comes along, and macular degeneration, whether it has environmental factors, it has genetic factors, or nutritional factors, glaucoma. So that part of the aging process is also something very important to deal with, because if we keep our senses alive, our sense of seeing, hearing, our ears lose function as we get older. The membrane in the inner ear canals become thinner. The drum that is supposed to be so movable and sensitive becomes harder and stiffer. So we start to lose hearing. So getting good glasses, getting rid of your cataracts, taking something for your glaucoma definitely adds to your longevity, perception of aging, and the aging process. Getting a hearing aid definitely helps you stay involved in the life around you and not feel isolated. And the cognitive responses that your body is being stimulated and you're responding to. Having family members interact with you is always helpful, always welcome. Love. We need love in order to. Yes, we could use vaccinations to make sure we don't die of pneumonias and flu and measles, mumps, rubella, chickenpox. How do we respond to herpes, and how do we respond to shingles, and how do we respond to COVID-19, and so on and so forth? Yes, they all have um, a great deal of a role to play in the process of aging. But as a closing, they haven't really established that certain cultures live longer. Well, certain cultures, certain locations may live longer because of the foods that they ingest, or maybe because of the family structure and support, or maybe because of the socioeconomical. And the socioeconomical doesn't have to be, I have to be a rich person. I have to be satisfied that I have enough, I can eat, I can live, I can do this for another 40 years or 30 years. All of these play a role in the process of aging, aging normally, aging gracefully. We look at, in America, static, aesthetically aging, white, wrinkles, so we want to stretch, we want to dye, we want to implant, all of those things. So it's more of a visible process of aging rather than really truly digging into it. But I think that if you have any questions, I'd be glad to take them. I am sorry I went a little too long. And thank you for the opportunity to share a few words with you. Minion?
Did you take the
Okay,
vote?
now go ahead.
Yes, yes. Do we have any questions for our Dr. Nagavi?
Good morning, Aunt Mignon. I do have a question. This is Dr. Sharon Henry Woodby, Aunt Mignon's niece. Can you talk a little bit more about immunity and the aging process? I think right now, top of mind is things that we can do to help bolster our immunity. Given the situation we're in with COVID, it's probably top of mind right now. So do you want to could you expand a little bit on that?
Definitely. So our immunity, our inherent immunity is basically based upon what the body responds to external stimuli, how it responds, how well it responds. I think we have to follow the same thing. Today, we are dealing with communicable diseases that are transferred through droplets and so on and so forth. But taking precautions and reducing our risk of exposure is probably one of the best things that we can do. Proper amount of sleep, cleansing our door, washing our face, washing our hand, as far as cleaning whatever we get exposed to throughout the day will help us. Immunity goes anywhere from, I have arthritis, to I have lupus, I have scleroderma, I have Sjogren's, I have osteo, and I have many other diseases. So part of today's treatment of this COVID-19, we are learning is suppressing our interleukin-6 or suppressing our immunity to not over-respond to the stimulus of this virus that is there to cause, pneumonia. So this is the whole concept of discussion between hydroxychloroquine, and I defer to our other colleagues to get their input in how they're dealing with infectious diseases and so on and so forth. But immunity, sometimes having our immunity, any autoimmune disorder is something attacking our body or our body responding to some sort of an external stimuli. And sometimes having some immunity is good. Sometimes having too much immunity is not good. And part of the treatment may always be you could give a patient, they are suffering from pneumonia, you're giving them steroids, you're giving them antibiotics, you're giving them nebulizer treatment. So you're trying to sort of balance between inflammation, fluid, secretions, to treatment all in one package. But with today's world, I think people have to understand, first is prevention, second is exposure and immediate seeking of treatment, and then it's the end result. Just as a point, we have had hundreds of patients with COVID-19. And throughout the process, whoever sought help and treatment early did fantastic. Whoever waited to the point of no return, 50–60% did poorly. So it's a matter of being able to seek help and being able to respond to the treatment. I hope that answers your question. Sort of.
Yes, it did. I think one of the things you pointed to earlier is our ability on an ongoing basis to help support our body, which includes our immunity, by our lifestyle. So I think the aspect of appropriate nutrition, taking in vitamin C, exercising, doing those things that are going to, and overall, put us in a better physical state, which will inclusively affect how our immune function is working, will put us on a better path in the long run. So I think some of the things you said about change is really critically important, especially as we age.
Absolutely, absolutely.
Thank you. Any other questions?
Can I ask a question?
Yes, please.
Marilyn. I'm interested in the effect of taking vitamins, vitamin supplements, and of that.
I'm sorry, I missed something. The effect of taking vitamins and supplements, I missed something you said.
Is that worthwhile? How does that affect the body? Is it a useful thing to do in the aging process as one ages?
Absolutely. I think the earlier you start the process, the better outcome you're going to get. If you wait until you are 70 to start taking calcium and vitamin D, you've missed the boat. Yes, you can build it, but you really miss the opportunity to prevent a preventable disease. Vitamins, our nutrition is poor. Even if we think we spend big money to buy good food and organic, our nutrition is poor. The quality of food that is available and is being given to us is not there. We don't have enough fortified and enriched foods like it used to be. The ground doesn't have enough minerals and nutrients to put in the food for you to consume it. So you must take a good multivitamin on a daily basis. Whatever brand you want, but it must have double or triple whatever the basic requirements are. Certain vitamins you don't want to overdose on, but you definitely want plenty of D2, D3, and calcium to build the bones, especially during the time that you're not in menopause. This is for men and women. Plenty of B complex, because the B complexes have a lot of function in the Krebs cycle. Plenty of vitamin C, plenty of minerals, zinc, magnesium, molybdenum, metals, copper, things like that. So absolutely, get the best food you can get organic, dairy, and take some sort of a supplement. But overdosing on 16 supplements a day instead of food, that's not it either. So everything in moderation.
And hormones?
as far as hormone replacement, you have to realize that once you start to do hormone replacement therapy, as a man or as a woman, if it's no longer, your body is no longer producing it, you can use bioidentical hormone replacements. It has its own benefits and detriments. They do cause complications like heart attack, stroke, cancer, blood clots, and other things. But so you have to sort of balance the two sides, the risk and the benefits, to be able to sort of say, I will do this, I won't do that.
Right, thank you very much. That was an excellent presentation, Dr. Nagavi. Thank you.
Thank you for the opportunity to give a tiny bit of input to our Global Health Associate development on an ongoing basis. Thank you, all the participants. I have some patients scheduled, and that's why they allowed me to go first through telemedicine. So I will say, have a great morning and the rest of the conference.
Yes, thank you. I just want to say briefly, Dr. Nagavi is a board member of the Global Associates, as well as Dr. Sharon Woodby Henry. Henry Woodby, my niece, and Dr. Reese. And we are going to start up eventually telemedicine with our village in Ghana. So thank you very much, Doctor, for being here this morning.
Thank you.
All right. We will now hear from Dr. Reese, Robert Reese. Are you there, Doctor? Dr. Reese, Robert Reese.
Hello.
Hello, how are you?
Okay, good morning. That was a wonderful presentation, Dr. Nahagib. Thank you. And, you know, as we all realize, this was supposed to take place a month ago. And Mignon, Dr. Smith, thank you for rearranging it. And I think what we have to be aware of is that this virus has put us into an unusually stressful situation. And that we're all aging more rapidly during this period of time because we're being deprived of human companionship. We're being deprived of proper exercise. In some cases where it's not available, we're being deprived of proper nutrition. And the mental stress of the whole issue is really aging us during this period of months much more rapidly. An old friend of mine once said that man plans and God laughs. And this is part of how you have to adapt. And we're adapting. A friend of mine also once said that if you get up in the morning and you're 60 years of age and you have no pain, you're dead. Going back to what Dr. Nagavi had pointed to, and this isn't dental, I called it a recipe for slowing aging and enjoying your life. The most important factor in living a long, satisfying life has nothing to do with possessions, which car you drive, how many pairs of pants you have, how much wealth you've accumulated. It's basically how many people you interact with on any one day. Human connection is what separates us from all other species. And digital doesn't do it. Looking into another person's eyes and talking and listening creates meaningful emotional gratification. And gratification is really one of the benefits and stress relievers. There's a little town in Sicily where most of the people seem to be living beyond 100 years of age. Why? I think there are some very, what shall I call it, practical reasons. They have a close community and personal connection. They don't eat processed foods. They don't have cars. They walk everywhere. They sleep 8 hours a day. They're basically not taking any medication. And the stress level is much lower than we experience here. So, you know, at every age, at every era in life, we age, whether we're 10, 20, 30, 40. But having an outlook in life which is really optimistic is much more beneficial. We have to think this day is much more important than tomorrow. Many people have far-reaching plans for life when they can retire and enjoy themselves. They're missing the value of the journey and only looking at their future needs. Bodies, as Dr. Naguib was saying, function, and it really was frightening listening to what he said is going on a moment-to-moment basis in this body. It's so fearful. It makes me fearful. How can I control all this? And basically, I think the body functions at its optimal situation by routine. The body loves routine. Eating at the same time, going to the bathroom at the same time, adequate amounts of sleep at the same time, exercising at the same time, adequate intake of roughage and fluids to stimulate proper bowel function. This will facilitate IRT, intestinal rapid transit. Try not to eat foods composed of more than 2 or 3 ingredients. Now, from a dental point of view, what do I see? As people age, some of them present mobility problems. They don't have the ability to come to my office easily, or they come with help, and sometimes they don't have help. Loss of visual acuity, which leads to increased accidents and more dental emergencies. As Dr. Naguib said, loss of hearing, which causes isolation and depression, and basically a failure on the part of the individual to do proper oral home care daily. The most important thing, or the negative thing that I see, is in our country, as people age, the number of medications that they're taking increases exponentially. And what this does is it causes dry mouth, decreased salivation. Nothing is more harmful to a proper dental mechanism than dry mouth, because the amount of geriatric decay becomes unmanageable. If saliva isn't there, there's nothing I can do. I see people every 3 months and decay increases because home care is inadequate and saliva is inadequate. Changing sleep patterns as they age, changing in urinary and bowel function, dementia and Alzheimer's causes a failure to really participate in proper home care to the oral cavity. Changes in food selection, due to inability to chew properly due to loss of teeth. And then you watch people gain weight and lose control of what they're eating. We also have to consider what a dentist diagnoses based on what's going on financially and visits that are possible. As people get older, they don't have the proper financial ability to pay for what they really need. And they also can't tolerate long or frequent visits. So what we face is a sad situation of patients consuming foods that are possible for them to chew when they don't have adequate teeth. Going back to what causes, what shall I call it, rapid aging, we have to think about genetics, where we come from, what our parents were like, and it also has to do with environment, but basically genetics. Exercise, whether we're getting enough exercise, physical and mental. Back to diet, real food, simple, unprocessed. Sleeping 7 to 8 hours a night. Stress, oh my God. Stress is the big killer. Human connection, not digital. Personal gratification, as Dr. Nahagib said, giving or doing for others besides yourself. And also satisfaction with oneself at the end of every day. Your attitude towards life. Is the glass half full or half empty? What we know is that your body, my body, everybody's body functions most efficiently in response to routine at any age. As far as foods, what would we recommend? Fresh fruits, whether it be berries, persimmons, grapefruit, papaya, anything fresh. Fresh vegetables, spinach, broccoli, watercress, beans, nuts and grains, seafood, fresh fish, water not in plastic containers, as Dr. Nahagib said. It drives me crazy to see people walking around the city in hot weather with water in plastic containers where the container is being leached into the water. Unbearable. Coffee and tea, fine. Eliminate processed foods. Eliminate as much red meat as possible. Eliminate artificial sweeteners and artificially sweetened beverages. Limit your salt and alcohol intake. Another problem that's existing more and more in this country, as people live longer, they're taking more prescription drugs. 80 to 90% of these drugs have as a side effect, as I said before, diminution in salivary flow, which we call dry mouth. This condition causes an enormous increase in geriatric caries. Very different than juvenile caries as to where it occurs. Geriatric caries tends to occur everywhere, circumferentially around the gum tissue, interproximally, whereas juvenile caries occurs at the junction point between teeth and is easily treated. Geriatric caries frequently involves extraction or crowns and things that might be well beyond the purview of the individual. We have found that older patients who've had implants to either replace missing teeth or act as a basis for holding removable prostheses in place function very well. They eat everything, and their nutrition and digestion do not suffer the previously mentioned changes. it would be wonderful if we could include implants as a natural benefit of any medical program federally. And we should be entitled to it as citizens of a very wealthy country. Mignon, thank you. Any questions?
Thank you, Dr. Reese. Any questions for Dr. Reese? I always have to say this. I think it was 1958 when you became my dentist.
Is it that long?
1958, yes, until present.
Yeah.
A long-time relationship. And I thank you very much.
And a loving one.
Thank you. All right. We will hear from our next speaker now. Are you there, Barbara? Mrs. Barbara McFadden is an expert with nursing home care as far as governance is concerned. And Barbara, are you there?
I am.
Okay. Thank you.
I'm going to share this screen. I have a PowerPoint presentation, so please bear with me. This worked so well last night.
Do you see the button for share screen at the bottom?
I'm getting it now. I'm bringing up my slideshow.
Okay.
Is everyone able to see this? Is everyone able to see the slides?
Yes, it's good.
Okay, thank you. Good morning, everyone. Thank you very much for getting up so early on a Saturday morning. And I have to admit, so that we can all laugh about it, is that only the mature would be up this early and intellectually engaged. I think the Gen Xers and the millennials are probably still sleeping, and we talked about having a full night's 8 hours of rest. As I look at the house here where I live in this multi-generational house, everybody else is still sleeping. I don't know, I don't understand it, but I'm sure that at some point I will get some wisdom as to how all this transpires. Again, good morning, and thank you very much for your time and attention. The overview of my presentation is in 4 parts. The evolution of long-term care, summary of long-term care, and I wanted you to also look at some of the services here on Long Island. It's a biased presentation, and I think that needs to be said at first juncture. because the service is available for those who are not of European ancestry, regardless of income. The opportunities for long-term care is not the same. And I'm bringing you this information really from an anecdotal perspective of, after serving and working for 50 years in healthcare, and certainly will be open to questions with reference to my bias as we go through this presentation. I want to also talk about the trends in aging. Has a lot to do with the previous two presenters in terms of the increase of the pharmacological aspects of taking care of or addressing some of the issues that we know occur biologically, as Dr. Nagev talked about and Dr. Reese talked about. And then again, looking at the future, which has a lot to do with the economic perspective going forward, because we are living longer. However, will we have enough people to take care of us as we age? Quite briefly, evolution of long-term services. We all have been somewhat a part of all this. America moved from an agrarian community to metropolis. Most of the caring for those who were ill or elderly took care was done at the home. Physicians did home visits. We have names for them now. We're community nurse, the midwife, the local person who cared for people. Whatever nomenclature we want to use, we know that we swiftly moved from care at home. People moved to the cities, and there was the space to include an intergenerational family diminished. And so unfortunately, those who were ill or elderly started progressively moving from home towards an institutional type setting. We look briefly, just giving you a very quick broad stroke of caring for folks. From the 1900s to 1936, care was done more, and unfortunately called poor houses, or they were taken care of by religious communities, or either Catholic, Protestant, people of the Hebrew faith. But nonetheless, the religious foundations of our of our life caused us to move towards caring for people in a humanistic way. And so however, in public settings, those poor houses, care was not to the optimal level that we would want. Around 36, with people beginning to live longer, and it's something that we're beginning to talk about again when we talk about Medicare for all. So there was the Social Security Act allowed for a retirement income. That's if you've paid into the system. And that's still very true. If you don't pay into Social Security, you can't reap the benefits of it at time of retirement. So there was a stipend paid to individuals, predominantly groups, and some of the people who traditionally had been in the care field and the care arena to take care of people in a congregate space. So that stipend incentivized building of nursing homes. Well, because of increased care for many of the reasons that were previously discussed through our esteemed colleagues, people started to live longer. They were living past 35, 40 years, and they were now moving to live much longer. So that fund utilized to incentivize and pay for a stipend for those caring for people begin to dwindle. So the risk of Social Security fund going, quote unquote, bankrupt started to be discussed in 1950. 1965. We were all young, bustling, and we all had beautiful, same color hair, no gray at all. In 1965, Medicare and Medicaid were created as an amendment to our Social Security Act. And it then diversified where the money went. Medicare, part of the Social Security Administration Act, paid for short-term rehabilitation, while Medicaid paid, nursing homes were reimbursed for those who were financially indigent. And so that still happens until today, but the payer system is quite different. Let's look at what happened from 65 to 2020. The increase in the pharmacological approach to any chronic disease, the fact that people were now living longer and going into hospitals, and hospitals became more technologically able to diagnose, able to provide some amazing care. If you go into a hospital today, you're not quite sure whether you're in the hospital to receive care or whether you've gone to a high-tech lab. And so, and I say that, if you think of the things that can happen to you from the time that you're triaged in the emergency room straight through to you get admitted, high-level technological approach, not so much hands-on and caring, but high-tech technological approach is now occurring in hospitals. So the acceptable standards of practice that we see in hospitals and all the other factors causing us to live longer increases the acuity of those people who now go to nursing homes. Let me just go back a little bit because I've gone through very quickly. People went to nursing homes early during our agrarian period, straightforward to the 50s and possibly the 60s, is because they had exacerbations of chronic conditions. And it was not to receive high-tech care. From the beginning until now, what can be done in some nursing facilities, nursing homes, you can go from having just care on a one-to-one basis to assist you in your activities of daily living, or you can have very high-tech procedures performed around the clock, the same as one did when I would say as early as the 60s when I started in as a nurse. Some of those things were done only in a hospital. People are being cared for in nursing homes that are on ventilators. People who are in nursing homes now have life vests so that if their heart stops, that is inactivated. People in nursing homes today are require 24-hour care. Nursing, when I retired a year ago, prior to my retirement in 2015, when I retired the first time, I was an administrator of a facility where over the years worked in having what's called a PEG replacement done at bedside. We would have not just intravenous initiated in the nursing home, but there's something called a PICC line, and that is an intravenous procedure where a catheter is introduced into a major blood vessel in a vein and goes all the way up most of it's done at the bedside, at the arm, all the way up to the beginning near the heart, and you can hang IVs. So you're having IVs through a PICC line, you have intravenous through a regular vein at the bedside. You're now having you're having people who are on respirators with respiratory therapists 24/7. When I say in that first bullet that modern medicine standards have increased the lifespan, those procedures were done at the hospital. You're now at the second bullet, you're now having high acuity patients who are in long-term care facilities. Not everyone is doing that, but there are some. So I just want you to have a broad stroke and understand that long-term care of coming and having someone in a rest home has gone from that to what you normally would have seen in a hospital on a medical unit. For those people who don't require that level of care, the trend is moving towards those who do require long-term care. And here is where you have aging in place and continuum of care happening. Our living space today no longer and our primary residence can take 3 levels of family: grandma, parents, children. Homes today are not usually built that way. Apartments are not set up that way, although people are living longer. So now we have a trend growing where many people, although there is no other place to go, or the decision is made, I'm going to age in place. I've said that, I'm aging in place. So if you choose to age in place, you are part of this growing desire and trend to age in place wherever it is, your apartment, your home, your condo. You may live there and live safely in an environment where you are living. So we're seeing more and more of that. So almost a circle, starting with us being cared for at home during our agrarian period. Now many people are saying, I'm not going, I'm staying home, and I want to stay in my own environment. I'm comfortable in this environment, and I want to stay. For those who are already in long-term care or desire to go, the long-term care organizations are expanding their services to home health, hospice, and a complete continuum. So if those who are in the hospital, in nursing homes now, you can have a full continuum of care. Hospice can be done in a long-term care facility now. Many have made arrangements to do that. So in addition to having ventilators and high-tech procedures being done, you can now have hospice in that place, which may have been your home for the last several years. But I want to go back to point number 2, the bullet point number 2. If those kinds of services are now being rendered, it's expected, and it's a matter of acceptable standard of practice, required standard of practice through legislation, through Medicare guidelines, Medicaid guidelines, which supersede many of the desires of any one or any individual. You must now have the appropriate qualified people in these facilities to take care of these high-tech procedures. If you're going to be doing, if you're going to now have a unit, as the facility I just retired from, you're going to have a unit where you have people who are on ventilated, quote, life support systems. You must have a registered therapist on duty 24/7. So the respiratory therapist must be there 24/7. you should and must, according to the standards, acceptable standards. It says licensed nurse in the regulations, but you should have a registered nurse on that unit all shifts, whether you're using a 12-hour shift or a 8-hour shift. If you're using an 8-hour shift, you need to have an RN on that unit every single shift. For 8 hours, 3 nurses. For 12 hours, should be 2 nurses. If the RN is not on that unit and is in charge, there must be one in close proximity so that the assessment feature, which is part of nursing regulations, only a nurse can assess, only a registered nurse can assess, not a licensed practical nurse. So if a licensed practical nurse is on that unit, a registered nurse must be in close proximity and easily accessible in case there is a problem occurring on that unit. You will probably hear in some nursing homes that they have a subacute unit. And the subacute unit is a unit which people normally would put these high acuity patients on and therefore increase the staff. For those people who now are wish to focus on person-centered care, and let's follow me with a story. Mr. Smith has no one to care for him at home. He has limited ambulation. He uses an assistive device. For this instance, he's using a walker. Has some difficulty with transferring from his bed to a chair. Needs assistance going to the dining area for meals. However, Mr. Smith is a manly man. He's been in the Marines. He's 100%, 1,000% Semper V. He likes to see active sports. He likes to have an opportunity to to use his television. He likes to use his phone, and he's not so keen on using a computer these days. But most of all, he enjoys his privacy. All of that information needs to be part of his plan of care and consideration if he has a roommate. Now, I said initially that he uses an assistive device to go to various places throughout this congregate living site. So it's the nursing home's responsibility, not for human reasons, but regulatory reasons, that his plan of care reflects his needs so that all of the staff taking care of him will be cognizant of what his particular wants and needs are concerned. It's been more focused, and interestingly enough, I think you should all note that in the Affordable Care Act, put extra restrictions and mandates, no, not restrictions, but mandates to all of us in long-term care that quality of life was key and critical. And because it is key and critical, it is expected on survey, it's expected not only from a regulatory perspective, but the family member who's interested and involved should be aware that the person's special needs, personal care needs are included. And so therefore, it's not arbitrary or capricious that a person an organizations that run a nursing home treats this in a cavalier manner. Now, as we go on and look at the kinds of things happening from just taking care of someone who just needs their bed made, who needs to be washed, dressed, and rolled to the wheelchair in a wheelchair, or wash, dress, and take a look at the sunshine as we initially started back in our agrarian period and up to even the 50s. As I just shared with you before, we now have some of the technological innovations that are now present in nursing homes. And this is not only from the literature, it's from my experience, and it can be substantiated. Nursing homes now are expected to have some form of an electronic medical record. You go to your physician's office, you see more and more that providers have some form of medical record. So there is an expectation. Just as your physician calls in your prescription to the pharmacy, and you very rarely get a prescription on a piece of paper today, long-term care is required to have this same electronic physician, electronically shared medication orders from the prescriber to the pharmacy. Computers for staff. When I say computers for staff, not only at their desks to communicate, but also in point of care tablets. I've had experience with using personal care devices that fit in the palm of my direct care workers, which would be my certified nursing assistants. They could have carried around with them, or they could have it neatly in a Docker space, where they record the care that's given to a particular resident. So here you have the CNA using a handheld device, and you have nurses who are using a computer on their med card or their treatment cards, and you're using electronic computers. Computers now, in one of the regs, I wasn't able to find it. I just know it on the top of my head. I could tell it, I could look it up, but you can be rest assured, computers are expected to be in facilities for residents' use. There are various creative ways in which people are taking care of that and doing it, but computers for resident use is expected. And it has a lot to do with many of us who are baby boomers are coming into facilities, that they need to wire facilities to be able to receive all these apparatus. Telephones are required for a resident. When I went into long-term care many, many years ago, there was at least a payphone, but you very rarely see that now. Most facilities have it set up so that there is a designated spot so that residents can have a telephone available to them. However, when I did have a personal experience to share with you, had a knee replacement 2 years ago, and went to one of our highly esteemed facilities on the North Shore. My phone was there, and I could have used it the same as if I were in an acute care setting, but of course there's a cost per day. And there was a television at the foot of my bed, and that was an additional cost. And again, what your financial resources will determine whether or not you will be able to make it available. And since I was on a subacute unit, most of the amenities there were very, very, very close to what you'd find in a hospital. Okay, televisions for residents at the bedside. There are some facilities that offer it as part at no cost. There are some facilities that put in a system, and there's a nominal cost for the resident. Let's look at the type of services offered here just on Long Island. I'm not going to go into them individually, but if anyone wishes, I would certainly have, if you would let Dr. Mignon know, I will certainly share my slides with you, and you can have an opportunity to not only see these, but also find my reference sources. The types of facilities and services here, you have adult home, and for those of you who are on Long Island here, there are 25 in Nassau, 44 in Suffolk County, and it just provides long-term residential care, room and board. So it's almost like the original old folks home. It's adults, and they provide room and board, housekeeping, and personal care. Now, you're going to see definite a name, but the services are beginning to morph into each other. And so I just want to share that with you. There's enriched housing. There are several enriched housing programs that are up here, 15 in Nassau, 10 in Suffolk. If you have an opportunity later on, go to the website and look at Dominican Village in Amityville. It's sponsored by the Amityville Dominican Sisters of Religious Order. And if you have an opportunity to go out and take a look, it's beautiful property. It provides long-term care, residential care. So these people who are there are able to get around on their own. They live in a congregate setting, but usually they have an individual room. They may have, they have some there with who are small apartments. According to their website, they're beautifully furnished, and there's a cost for being there, and it's done on a monthly basis. Then there's assisted living. You see many of these assisted living buildings that are all over Long Island. There are 18 in Nassau, 27 in Suffolk, and they offer personal care. They offer food service. It looks very much like those of us who happen to go to timeshares or hotels. It looks just like that. So you don't have to worry about your meals. Full activity across the board. Usually a chef on place. Activities are done by an activities therapist, who, by the way, I just want you to know, if you're working in a long-term care environment, there is a regulation which says that you must be certified. And so therefore, it's not just hiring someone who likes to play games and is aware. There's a whole host of things that you must be aware of, and there's a whole course of study to be in a position to provide an activities program. Then you have enhanced assisted living residence, and it provides a more personal care in that they require physical assistance to walk. So you realize the challenges are there. They persons require assistance of another person to climb stairs, and they depend on medical equipment. Now, understand that in a assisted living, you can live in that environment if you have a scooter, or you walk with a cane, or you have a walker, and you don't need incontinent care. You don't need hands-on assistance. Many of them are morphing to have these services included in their full array of services. Then there are special needs residences that you'll see for people who have dementia or cognitively impaired. There are 14 are listed according to the regulations and the state, and 18 are in Suffolk. I don't know where these places particularly are. They're usually isolated. They're usually on the grounds of some of the established organizations that I've just mentioned. So you can understand that they don't always occur in silos. They may be integrated into an assisted living environment that you may see. Now, an assisted living program, an ALP, I just want to talk about this a little bit longer. There are only 6 in Nassau and 6 in Suffolk. What I can't determine at this point to tell you specifically where they are, I can tell you that the host of services that is offered is usually on the lower end of payment. When I say lower end, many assisted living, the cost of being engaged in being a resident at assisted living, the costs are higher. And I'm not going into the cost because many of the costs are proprietary, very difficult for me to share with you. It'd have to be on a one-to-one basis. But I can tell you that there is more out-of-pocket expense to go into an assisted living. And if you are medically indigent and you require the services I've discussed previously, it tends to be more cost-effective to remain at home, because the cost of living in an assisted living is considerably higher and takes a great deal of your finances. Once you are in those assisted living, there is a mechanism for you to begin to spend down. And when you finally are at the point where you are considered medically, financially indigent, many of them allow you to stay as long as your care needs do not require a level that they are unable to adjust. So, to be quite specific, you are managing on your own, you're able to ambulate on your own, your ambulation is difficult, you now need a wheelchair. You've gone from a cane, a walker, wheelchair, you having some occasional incontinence. That's a level of care that assisted living is not inclined to offer. It's not part of what they will offer. However, they will look at your resources, and there is a manager on site who will assist you in qualifying for Medicaid. Now the problem is finding an ALP that will assist you. And I'm quite surprised that there are 6 in Nassau and 5 in Suffolk. They're very difficult to find, and not only difficult to find, very difficult to get into. I encourage all of you to use your computer and take a look at Amsterdam at Harborside. Amsterdam Nursing Home in New York City has been one of the leading healthcare institutions in New York City. Very large, has been very much involved in innovating new trends. But they decided some years ago, perhaps maybe now 8-9 years ago, to develop what's called a continuous life care community, where you would stay. You wouldn't have to go through the transfer. So you would stay as a healthy senior and straight through till you would need long-term care, all on the same campus. You don't leave at all. And it offers a range of caregivers at all levels. You don't have to leave the site. You can stay. If you happen to have surgery done or a brief hospital stay, they have a small nursing home. I don't even think if it has 20 beds in a particular building. You can go there for short-term rehab. You can go for your bout of illness, your exacerbation of chronic illness, and you need 24/7 care. But they're willing to send you home, and you don't have to go to your apartment. You can go to a nursing home that's on site. But I will have to say to you, it is not cheap. At one point, someone told that the buy-in is around $1 million. We're not sure. They offer something called Life Care. It's, as I said, it's an investment that offers solid plan to protect you against future rising healthcare costs. The financial structure is set up for individuals or couples to pay a one-time entrance fee and monthly service fee for priority. And they offer memory support, skilled nursing, rehab, as I just said. And the upfront entrance fee provides for access to preacher care. I want you to take a look at the pictures of the folks that I put there, because if you do see that, it's a picture from their website, and it also substantiates what I would say is bias in that at Harborside, you probably would not see anyone of African descent or someone of Hispanic descent at all, regardless of income. It offers an incredible range of dynamic floor plans with 1 to 2 bedroom options, all are appointed with spacious kitchens, granite countertops, stainless steel appliances, full range of washers and dryers, walk-in closets, all of that's offered. So it's a home away, it's your new home. Many people, I understand, sell their current home and move in, because you have, it's one price you pay, and you offer these services. The trend, I'm sorry.
Barbara, I might have to interrupt because we have one more speaker, Melody Graham,
Okay,
and not that much time.
all right, I will conclude by saying, as we go from now until the end, until going forward, I just want us to all realize that the number of those of us who are 65 and older, that number will double over the next 30 years. And the sad statistics is that the need for direct care workers will certainly increase. However, we won't have the opportunity to have the direct care workers to be there to assist us. Thank you very much for listening to me, and I certainly enjoyed this. Have a good day, everyone.
Say thank you. Say thank you.
Oh. Our next speaker is Melody Graham, and she is a financial expert as far as senior living is concerned. Melody? Melody is also a lawyer, but she prefers to do this type of endeavor.
Which I've been doing for over 25 years. Thank you, everyone. Some of the material that I'm going to be going over was covered by Barbara, but I'm going to talk more about the finances involved in long-term care. So let me see if I can share my screen. And if I can't, then we will persevere. Can everyone see my screen?
Yes, it's coming through nicely.
Okay, fabulous. Fabulous. Okay, so as I said, I'm going to talk about long-term care services. How much do they cost, and how will you pay for them if you're in need of such services? For long-term care, most of us would like to think that this is not something that we're ever going to need in our lifetime. but in fact, over 70% of those of us over age 65 are going to need some type of long-term care services. Now, what is long-term or extended care? Barbara gave a very thorough discussion of long-term care, both its history and its current iterations. But I'm going to go through that a little bit. In that long-term care consists of both nursing home care, and assisted living facilities. I'm also going to mention that in order to receive long-term care coverage, generally you have to be unable to perform some of the activities of daily living, which include bathing, walking, dressing yourself, being able to eat on your own, although that doesn't include preparing your food, being able to go to the toilet by yourself, and being able to transfer from your bed to a chair, or from your chair to a bed. In addition, doctors and insurance companies also look at whether or not you have a cognitive impairment, and that includes dementia or Alzheimer's. In terms of the costs, the average costs for long-term care nationwide is about $92,376 per year. That averages to $253 a day. And the general length of time that people will remain in a nursing home is about 3 years. So the total costs will average about $277,035, but that's nationwide. Of course, here in New York City, the prices are so much higher than they are in the rest of the country. So, New York, a semi-private room in a nursing home might cost about $11,750, which averages to $392 per day. If you have a private room, it's over $12,000, which is about $400 per day. If we look at a lower cost state like Florida, the prices are generally half of the New York state prices. If we look at assisted living facilities here in New York, the average monthly price of living in an assisted living facility is about $5,900 in New York City. Again, in Florida, it's about half that. And lower cost is home health care, which is what most people prefer. That averages about $4,920 per month, and that's about $164 per day. These costs are astronomical, but they are in fact the costs that we have to deal with. In paying for these costs, there are several areas that we can look at in terms of payment. First thing I wanted to differentiate between Medicare and Medicaid. Under Medicare, Medicare pays for short-term care in nursing homes or rehab center, usually up to 100 days. And thereafter, either you're expected to go back to your life, or if you need additional care where you cannot take care of yourself and you cannot perform the activities of daily living, that's where custodial care comes in. And as I said, it can be any number of things, such as a nursing home, home care, or assisted living. In paying for these for any of these facilities, you can go through Medicaid, fund it yourself, traditional long-term care insurance, and life insurance with a chronic care rider. Self-funding is exactly as it says. You pay as you go. If you have a good pension and you have decent assets, you may be able to do that on your own. But as I said, it's very expensive to go that way, and you might want to offload some of that expense to in some kind of insurance plan. If we use Medicaid, Medicaid is the government program that allows you to have some form of custodial care. However, the requirements to be able to access Medicaid are quite high, and for most people, they're unable to. For a lot of people, they're unable to meet the criteria, but they try to. Also, you have to look at each state and what their Medicaid payments will cover, and whether or not you want some choice in what kind of care that you get. Now, if we look at Medicaid, the requirements include a low income. So for an individual, that's about $10,500 per year. If you're a couple, it's $15,400. And your resources, meaning the assets that you have available to you, can only be $15,750 if you're single, or $23,100 if you're a couple. Also with Medicaid, there's a 5-year look back regarding the transfer of assets if you decide to transfer assets out of your name. Now, there are two types of Medicaid that are available. One is chronic Medicaid, and the other one is community Medicaid, and they have different requirements. Chronic Medicaid, it's much more stringent than community Medicaid. With chronic Medicaid, your home is not exempt unless you intend to return to it, or your spouse, a minor child, or a disabled or caretaker child lives in the home. In addition, under chronic Medicaid, all of your income is paid to the nursing home as a contribution for the cost of care, with the exception of $50. They do have an allowance. It's called the Community Spouse Resource Allowance, which enables to the non-Medicaid receiving spouse to have some control over their income and their assets. And under the Community Spouse Resource Allowance, they are allowed to have $74,820, or up to, if it's a couple or if it's jointly owned assets, $128,640. This is in 2020 numbers. They're allowed an income, again, the non-Medicaid spouse is allowed an income of $3,216 per month. And if they have an income that's greater than that, at least 25% of the excess needs to go towards the cost of care of the spouse that's in the nursing home. So as I said, these requirements are quite stringent. Under the community Medicaid coverage, it's a lot more lenient. Community Medicaid covers home care, and your home is exempt from Medicaid up to $878,000. Also, your qualified retirement accounts, such as your IRA or your 401k or 403b, are also exempt as long as you are taking your required minimum distributions from those accounts, which is counted towards your Medicaid income level. Any income, again, this is under the Community Medicaid program, any income in excess of the Medicaid limit can be kept in a pooled trust to be used for the beneficiary's needs under Community Medicaid. And the 5-year look-back period is also, there's no 5-year look-back under Community Medicaid, so you can transfer your assets during that 5-year period. So it's a lot less stringent than chronic Medicaid. Another program is, of course, the traditional long-term care insurance policies. Now, these can be quite expensive. Long-term care policies right now, for an average person who starts out at age 60, the premium can be like $300 to $400 per month per person. The cost of insurance is based on your age and your health. So you have to go through underwriting to go through something like this. Also with the long-term care insurance, even though it's great in that you have inflation protection that's usually built within the policy, so that if you're an average person who gets a policy at age 60 or 65, you might not need it for 20 years. And of course, at that point, the prices have gone up, but your policy has an inflation protection provision, which increases the payout level as time moves on. So that's one good thing about it. Also, you're able to get a couple's discount if possible, if you're part of a couple, either married or domestic partnership. So that's what's good about it. The drawbacks to having this type of policy is that the insurance company is allowed to raise the premium rates if the premiums are not covering the level of service that's required. And that has actually happened over the past couple of years with most long-term care policies nationwide, because the insurance companies years ago, their actuaries in calculating how much would be needed for each policy made the assumption that the average nursing home stay was 3 years and the average home stay was about 6 years until people passed away. But in reality, since most people have decided that they would prefer to stay in their homes rather than go into a nursing home, they've been living longer than what the actuarial tables showed initially, based on nursing home, on people staying in nursing homes. So because they were living longer, the payouts were longer and the insurance companies were finding themselves underwater. So several insurance companies actually got out the business, still maintaining the policies that they'd already sold to people, but they got out of selling new policies. And other companies decided to increase their rates. And rates have gone up anywhere from 30 to 50% to keep up with the claims that people are making on these programs.
Melody, can we summarize?
Yes,
I'm
gonna.
Because you're running over. We have unlimited time, but.
Okay, I'm going to just round up with the next problem.
Interesting.
With the next program, which is life insurance.
Yeah.
Life insurance with the chronic care rider that has a death benefit. It's for someone who needs life insurance. If you don't need life insurance, this isn't going to work for you. You have a death benefit of $500,000. I'm using this as an example. You have a rider benefit, which sets aside $300,000 of that $500,000 for chronic care. You take out the benefit percentage of 2% on a month-to-month basis, which averages about $6,000. And that can work for you for a little over 4 years. What's good about this kind of rider is that it's predictable in that the premium that you're paying now is the premium that you will pay later. You don't have an increase of premium like you do with a long-term care policy. But the disadvantage to having something like this is you don't have any provisions for inflation. As I said, you might get this policy in your 60s, but not need it until your 80s, at which point the costs of long-term care have increased. So you're not able to keep up with that, but at least we'll be able to defray some of the costs associated with long-term care. And you also don't have individual benefits available. You only have individual benefits available to you in that you can't get a couple's discount. So each of you as a couple has to get your own insurance policy. So I've just been able to give you the features and the benefits of each type of payment plan moving forward for long-term care services, and how much they cost and how much you are going to have to pay for them. So the next step for anybody who's looking at something like this is looking at what's available and exploring your options. And I wrapped it up. My screen is frozen, so I look like I'm in mid-sentence, but I think we'll be fine.
Do we have any questions among our group of audience here? Thank you very, very much for this presentation. We tried to demonstrate all aspects of aging. And someone made a comment before. Gee whiz, Mignon Smith is having this program and she's 94. I'm 92. And this was very enjoyable. And I'm so happy to have this opportunity to share with everyone. Thank you. Nice seeing you, Vicki. Vicki is with us from Toulouse, France. And
Oh, how wonderful.
yes. And this is my lovely niece here. She's a resident now in Florida. And where else are you living?
New Jersey.
Okay.
Yeah.
And Martha's Vineyard.
And Mignon, Kathleen, and Marilyn are also in France. They're in Paris.
Oh, you're in Paris?
I'm in Toulouse. They were in
Okay.
Paris.
Yes.
They were in Paris.
Yes. And your daughter, where is she?
She's here. She's
It's
here. She happens to be working in Germany this summer
Oh,
for
oh,
a law firm, but she's working remotely.
all right. Yeah.
Isn't that weird?
Gloria, Melody, Vicki studied at Harvard, and she
Hi, Melody.
friends with Michelle.
And are they done?
Yes. Used to be Johnson, right? Michelle.
Where is?
What's your maiden name? Vicki.
Yeah,
What was Michelle Obama's maiden name?
Robinson, Michelle Robinson.
Okay.
But
Well,
she's
nice that
she's
you were-
12 years after me.
Oh.
I graduated in 75.
Want to answer a question? We can do a chat, a question here.
Mignon, I just wanted to thank you.
Yes, yes. My
I
good.
want to thank you as well. It was excellent.
Very good. Very good. All
I
right.
hope we're going to get the slides.
Yeah, we're working on that.
Great.
You
Great.
will. Okay.
Happy Mother's Day.
And to you and everyone, happy Mother's Day.
Thank you. Thank you.
And our best to Jasmine, you know.
Okay. I'll tell her.
Closing remarks.
What?
Give some closing remarks.
Oh, some closing remarks. Did you want to say, where were you, Anthony? Yes, yes. Well, I think I made my closing remarks, but I just want to say how grateful I am for this audience and the participants. And we did cover all aspects of aging. And thank you very much, Anthony. Are you there? You're muted, Anthony. I can't hear you. Cheryl, what are you doing?
Okay, continue talking.
Landia,
Yes. Can you hear me?
yes.
Okay, I'm sort of new with this Zoom, so I was playing with this the whole time.
Okay.
I enjoyed it. I had some questions, but I'll have to get to them later.
Okay. That's another niece. Landia is in North Carolina.
Correct.
Yes.
Very informative. I enjoyed it. Thank you for inviting me.
Thank you, Landia.
Thank you, Mignon. This is Leora.
Okay.
Yeah. Yes, thank you again, Dr. look forward to seeing you when we're out of isolation.
Definitely, it would be my pleasure.
Mignon, thank you again. I apologize. I'm able to get sound now.
Oh, very good.
All right, okay.
Thank you, everyone.
We're all in this very strange
Thank you, Mignon, and thank you, Anthony.
I'll start by saying, how are you? You know, which you don't typically do. Typically, it's like, okay, I'm coming from one meeting, I have another one. Let's just get down to business, you know?
All right. Where is Imhotep? He's gone.
Yeah.
Not yes. This is my family.
There's Imhotep. He's there.
All right. Goodbye, everyone.
Hi, Tap.
Okay, bye.
Bye.
Mother's Day.
Mother's Day
Mother's
to
Day.
everyone.
And for Christmas, happy Mother's Day.
Happy Mother's Day, everyone. Thank you all for joining.
Thank you.
Mignon, did you want to mention the upcoming event?
We're planning to discuss COVID-19 next weekend. We'll see how it works out. Everyone will be notified.
Okay, very
Thank
good.
you.
Thank you, everyone.
Yeah.
Thank
Okay.
you.
Thank you.
Thank you.
Bye.
Have a good weekend.
Thank you. Bye.
Bye. Be safe.
Oh, there you are.
Yes, yes.
Okay.
How's everything?
Good, good.
You're looking lovely.
Where are you now?
I'm in California now.
Okay. This is my grandnephew and a Marine. And what level are you, Imhotep?
Sergeant Major.
Okay, yes. We're very proud of Imhotep. And he brings peace to us all. Peace, walk in peace.
Yes, ma'am.
Okay. All right. See you later.
All right. We'll talk to you later.
everyone.
All right.
Thank you. Bye.
Bye-bye. Bye-bye.
Bye, Cheryl.
Okay.
Hang up.